Thank you, Mr. Chairman. Good morning. Okay, I'm going to talk today about the revascularization below the knee segments. We have different terms here we are going to shuffle through, so I have no conflict of interest. In everyday practice, all of us asking the same question for our cases. What shall I do with CLTI? Is one straight vessel is enough for wound healing? What is necessary and sufficient, single vessel or complete revascularization? And what about the below the knee? Below the knee area still, even with our practical everyday, it's a foggy area. So in my mind, it's always a demand-supply ratio. What one needs and what we can offer. So below the knee having a big debate about the multi-vessel revascularization or single vessel revascularization. We have a lot of terms. We have target artery path, wound-related artery, angiosome, and recently wondosome. So we will go through this one. The revascularization, single or multiple, we have multiple data about single and multiple revascularization theories. And all related to the outcome. The multi-vessel dilatation will increase the fluid perfusion, increase the fast wound healing, and increasing CLTI salvage. So the same question is multiple or single revascularization. We can see in such paper that 0 or 1 vessel having 1 better than 0 or 2 and 3 vessels better than 1. And the result here of limb salvage is markedly improved in regard to 1 vessel recanalization. So what is with multi-vessel revascularization? The tibial patency rate are poor, as low as 30 to 50% in primary patency in 12 months. And the higher rate of patent vessels suggests that betal tolerance was losing patency in one of the feeding vessel. And in contrary, what is against? It's increasing the cost, increasing radiation exposure, and increasing contrast volume. So there is still no balance between this. So does it really improve the limb salvage? In most of review of literature about the same multi or single vessel revascularization, we can see that single tibial artery revascularization, whether ATA or BTA, yielded incomparable improvement, giving same effect in microcirculation as the foot. So one or multi is the same. Again, in such paper, patient with isolated tibial intervention having poor outcome. Again, only one amendable artery can improve the foot salvage. The Vascular Quality Initiative concluded that the patient with CLTI and BTK multivessel disease didn't have benefit from limb salvage from multi-vessel revascularization. So this is the Vascular Quality Initiative, and it was including 10,000 patients and 761 follow-up. And it was a key to improve the quality of life, promoting wound healing and retaining function, improving the inline flow. However, more doesn't seem to be better. But there was some limitation for this quality initiative, that this number was started with 10,000 people, but the follow-up was 760 only. There was no long-term follow-up, no information about wound healing, and no data on pedal arch status. So we came again to target artery path, wound-related artery, angiosome, and a lot of systemic data, systemic reviews, and literature about this one. Does it really improve the wound healing? Okay, so we jump to the direct revascularization. Direct revascularization appears to result in improving wound healing and limb salvage rates compared to indirect revascularization. As we can see, the wound interfered with one angiosome is only 24% of the cases, and in conclusion, it was the tissue lesion affect several angiosomes. It's not one area, it's affected by multiple angiosomes. So what is with direct revascularization? Direct revascularization achieves better wound healing, shorter time of wound healing, greater limb salvage, and no effect on mortality. And in contrary, the quality of collaterals not uniformly described. Indirect revascularization with good collaterals can give the same effect, and indirect direct revascularization patient may have failed direct patient with more severe disease. So the ESGS showed us the glass score and the target artery path definition that you can use the best option in BTK vessel to have inline flow to the foot, regardless the angiosomal concept. And And the impact of angiosome target revascularization here, that it was in a retrospective study showing comparable result of direct and indirect revascularization regardless the angiosomal concept. So we jumped now in 2024 to the wondosomal theory by our friend Lorenzo Petron. And I was honored to be one of those more than 160 KOLs in worldwide global papers that published about the wondosomal theory. And the idea is the perfusion, not the artery itself, it's a perfusion to the wound area. How we can maximize the perfusion to the wound area to have a faster wound healing. So the concept of preferred target artery pathway doesn't include the comprehensive analysis of the BTA anatomy, doesn't address specific mechanisms of established suitable perfusion to ischemic foot, or whether direct or indirect vessel included in this one. I will show some examples about this wondosomal theory and how we can achieve different maneuver if we targeted an artery that gives direct perfusion to the wound area. The first case is a 70-year-old female, diabetic hypertensive, CLI with RC5 with heel gangrene, SFA total occlusion, BTA total occlusion, and poor heel perfusion. Can we play the video, please? Okay, so we can heavily calcified vessel and total occlusion of SFA. Then in the second video, we can see that the trial of revascularization succeeded with the SFA, but we targeted the posterior tibial artery as the main perfusion for this area because the arch is not complete and diseased, and we tried to manipulate antegrade for the posterior tibial artery, but it's a heavily calcified vessel, so we had a perforation. I tried to go through pedal plantar loop, and hopefully I succeeded to pass from the anterior to the posterior to the plantar arch and recanalized in a retrograde manner. Then we had at the end balloon dilatation of this heavily calcified area. And can we play this video, please? And we have a perfusion to the calcaneal branches, and this increased the perfusion to the calcaneus part. So we had this at the beginning, but we didn't give up. So we had this maneuver for pedal plantar loop, and hopefully we have now this perfusion to the calcaneal area. So next case is a 73-year-old female, diabetic, hypertensive, end-renal disease presented with RC5, big toe gangrene, SFA total occlusion again, BTA total occlusion, and poor heel perfusion. Video. So as we can see here, the SFA segment is intact, but the BTK segment is different. It's heavily atherosclerotic. We have anterior tibial artery, but we don't have. We have posterior tibial artery, but we don't have the anterior tibial artery. And as we can see here, I went from the antegrade vessel, but again, I failed to recanalize the anterior tibial artery from antegrade vessel. As we can see, some dissections in perforations. I stopped the maneuver. Then I tried to go in a retrograde calcium guided, and it was a heavily calcified vessel, as we can see here, going with an XT armada supporting from the retrograde axis with a O14 wire, trying every time to do some pre-dilatation to proceed few centimeters. It was very calcific, very heavily calcific vessel. We went through the subintimal space to the whole anterior tibial arteries, then jumped to the popliteal and snared the wire from antegrade axis, and we had the final angio is, I think in this one, yes. So we started with no flow in the anterior tibial artery, like this. We don't have anterior and posterior, only peroneal artery. Then we had subintimal space dissection and perforation. Usually, we think of artery with axis. It succeeded through the calcium guided. Then we have the anterior tibial artery targeted maximum perfusion to the big toe. So in conclusion, multi-vessel revascularization doesn't have strong proven support over single-vessel theory. The recent guidelines summarize that the angiosome-guided revascularization may be of importance in endovascular intervention. However, in endosomal paper, it doesn't support this idea because there is a lot of pitfalls in this theory. Looking at the wound, evaluate the target artery bus multi-level vessel disease and pedal arch status. In patients with small, minimally infected wound, the target artery bus is sufficient provided optimal balloon angioplasty is achieved. Also, we had some pitfalls about the initiative about this one. And most of wounds have multiple angiosomal feeding vessel. Having direct artery is preferred if feasible. And future studies and trials should be validating these technologies and strategies for assessing tissue perfusion before, during, and after revascularization. Thank you.